Greetings everyone. Welcome to the 126th session of the online Optom Learning Series or OOLS. Now before we begin, let me take this opportunity to wish, today is the International Mother's Day. So I would take this opportunity and time to wish all the mothers who are attending and all the mothers of those who are attending the session a very happy Mother's Day. And for today's session, we have with us Dr. Carrasquillo. She's the Vice President of Clinical and Professional Affairs at Boston site. And in addition, she's also an adjunct clinical professor at the New England College of Optometry and also at the School of Optometry at MCPHS University. She's on the advisory board of the GPLI, which is the Gas Permeable Lens Institute. She holds a couple of fellowships. She's a fellow of the American Academy of Optometry, the fellow of the Scleral Lens Education Society, and also the fellow of the British Contact Lens Association. Recently, she was also appointed as one of the global ambassadors by the BCLA. She has authored various peer-reviewed papers and publications, majorly on the therapeutic use of scleral lenses and also the prosthetic replacement of the eye surface system, which are popularly known as the PROS device. And also she holds several patents to her name. Prior to completing her doctorate degree in optometry and the residency in cornea and contact lenses, she has also completed a PhD in chemistry from the University of Puerto Rico and a postdoctoral fellowship in ophthalmological research from the Massachusetts Eye and Ear Harvard Medical University in Boston. And very recently, I think the latest publication which I was reading, which came out, shows that Boston site is the #1 publishing institute in terms of scleral lenses. And I'm sure that Dr. Karen has been an integral part in teaching and in sharing about scleral lenses to the world by the way of publication. And today she's going to talk to us about demystifying scleral lenses. She's going to take us through some cases where scleral lenses have worked out wonders. So welcome, Dr. Karen, onto our platform. And let me just leave the screen time to you.
Well, first of all, thank you for the invitation to be with you in this special day, Mother's Day. Happy Mother's Day to all of you as well. And thank you to the online optometry learning series for this kind of invitation. It's a pleasure to be here with you today. And we're going to be discussing a topic. Title is Demystifying Scleral Lenses. And we're going to be going over 3 major topics, approaching the physiological endpoints of what is required to achieve a good physiological endpoint around fitting parameters when we treat our patients with scleral lenses. So as kindly it was mentioned, I am the VP of Clinical and Professional Affairs at Boston site. I do not have any proprietary interest in any of our Boston site technologies, PROS or Boston site Scleral. So just as, get us started this morning, we have a paper that was published in 2018. It was a bibliometric study on scientific research on scleral lenses, right? And in this paper, in this bibliometric study, what was seen is that there was a significant growth in publications and studies related to scleral lenses, especially between the years of 1960s and 2016. And especially with a significant growth, over 200% growth in studies focusing on scleral lenses between the years of 2012 to 2016. The reason this is important to highlight and why this is important to focus our talk for today is that this highlights that there is a huge benefit for all of us that are interested in doing this, because this is now receiving global attention. Scleral lenses are not just dedicated by some few in different countries. Now this has a global reach and global attention, so that is a very important benefit that we're learning. But something that we need to keep in mind is that most of these studies, though, are studies that are based on short-term studies as opposed to long-term studies. And we have to keep in mind the reality of a scientific study, right? And it has its strengths, but also they can have their limitations. And that is because research studies, we all know that most of the time have a particular focus at a time. And when we study some of these topics, we sometimes focus on specific parameters, and we're not really studying the whole system, how the whole system come together to determine an endpoint. Usually there is a study on a specific population. And as I said, the duration is important. And most of these studies that have been published in scleral lenses, these are short-term studies. And so with that in mind, we have to be careful sometimes with some of the conclusions, because we just need to make sure that we don't draw generalizations, broad generalizations from studies that are very focused and perhaps short-term in duration. Not only are the distribution of most of these studies, more geared to more short-term instead of long-term, but also the sampling of a lot of these studies in scleral lenses are samplings of small numbers, small n's. And we know that for good statistical significance, we need at least a sampling of 30 or more. And so that's also important for us to take into consideration when we read some of these studies and read some of the conclusions that come about from these studies. And as it was pointed out in this paper from 2008, what are the strengths and limitations of small studies? There's clearly, benefits to small studies, especially well-designed ones, but we just need to be careful with the interpretation. Just as this quote says, taking directly from the paper, while small studies can provide results quickly, they do not normally yield reliable or precise estimates a lot of the times. So it is important for us not to take strong conclusions about a risk factor or trial intervention. And as I said, we just need to make sure not to make broad realizations. And I think that the beauty of small studies is that we can use the results from small studies to then design better studies and then hopefully carry them out with a larger sampling, larger N, right, for statistical significance, and hopefully carry those studies over longer periods of time. And that's how we can probably start to get a better understanding, more reliable conclusions to the questions that we ask. And so in the meantime, right, until we have access or outcomes for longer studies, so what do we do about what the clinical experience or clinical outcomes, have taught us? What do we do with real eyeballs that have been fitted in these lenses for 13, sometimes almost 20 years, right? Do we take these results, that these cases not part of a long study in particular, but should we just qualify these as just simple anecdotes and not give them value? Or should we instead take these cases? These are real patients with real pathologies, right? Not normal eyes or normal subjects. These are real patients. And then we take these outcomes and say, hey, let's question some of the studies that we see from these smaller studies, and maybe hopefully we question and then help us formulate perhaps more questions and better studies so that we can get a better understanding long term. So today, with this in mind, we're going to be talking about 3 topics. One is scleral lenses and IOP, the effect of the lens vault or lens clearance on hypoxia or edema, or, because a lot has been said about that. And then long-term outcomes with older grafts. Is it possible to get a good outcome with scleral lenses with grafts that are more fragile or perhaps compromised? Is there a specific number in endothelial cell counts that are required to achieve good endpoints? So we're going to be discussing cases in these 3 topics. So let's start with the effective clearance or the vault in hypoxia. So just to frame this, I just want to share a case that I published together with a colleague of mine in my clinic. This is a case of a 41-year-old male with history of keratoconus that came to our clinic with complications from hybrid lenses. These lenses were too tight, and as a result of tight-fitting hybrid lenses, we fitted this patient with our devices back in 2010. So quite some time ago, 11 years ago, right? And so this is the presentation of this patient as a result of these hybrid lenses. So you can see there's a significant haze and neovascularization in the right eye. But when we look at the left eye, this eye is way more compromised than the right, although the right looks pretty compromised already. We can see that the extent of the neovascularization is almost encroaching the visual axis. There's more significant haze, and we have signs of lipid keratopathy. So it was important for us to move away from this hybrid lenses. He was referred to us so that we could offer the scleral lens option, so we're not touching the cornea. And so back in the day in 2010, we were not really paying attention to how much clearance we were ending up with, to be honest with you, right? It was shortly thereafter that a lot of these seminal papers on clearance and hypoxia started to come out. Our focus has always been, the way we fit is we try to distribute the weight of these lenses over a broader surface area. And the more protuberant the cornea, the more we go out to distribute the weight. And the philosophy in fitting this way has always been aiming to minimize compression over time and minimize suction over time. We feel as though that is an important fitting endpoint to achieve. And very importantly, that we're not touching the limbal zone. We make sure that we have a homogeneous, aligned landing on the sclera, and we have the quadrant-specific haptics in order to do that. But we are also taking care that the limbus is not compromised. And more importantly, and I cannot highlight this enough, is that when we remove the scleral lens, we don't see any marks left behind. In other words, we should always stain that conjunctiva with sodium fluorescein. And when you remove the scleral lens, you should see no marks of the edges or around the limbal area, etc. That would be what we are always striving to achieve. But back in the day, in 2010, we were not really paying attention to the amount of clearance. And so you can see the outcomes from this patient who has already a significant compromised cornea coming in, as we saw earlier. And in the right eye, the vault was, about 350 to 400 microns of clearance. But in the left eye, which happened to be, the eye that was even more compromised, the endpoint was with a clearance way beyond 500 microns. And so we have learned throughout the recent years, that if we have a clearance that is probably more than 200 or 250, that we might compromise oxygen permeability to that system. And with that we might lead to sequela of hypoxia and potential complications of hypoxia. Well, let's see what happened with this case. As I said, that was already significantly compromised left eye, much worse than the right. especially with this outcome. We can see that in this patient, the diameter that we fitted, this was, I believe it was 18.5 millimeter lenses. And 2 months after, the right eye is almost like it's a different eye completely. You know, the left eye, thankfully, we still have some sequela of lipid keratopathy, as we had seen earlier, so that you can believe it's actually the same eye. Because otherwise, sometimes it would be even hard to believe that we're talking about the same eyes. And this was just 2 months after fitting. So we start to see remodeling of that cornea. 2 years out, this is how these corneas look. So the reason we published this case is that it gives us pause, because we said, hey, you know, if the clearance is the only parameter in order to dictate a good physiological endpoint, this cornea that already came so compromised would have potentially, and hopefully maybe you would all agree, would have potentially looked worse, because we, without knowing, would have created much harm to this eye, because our clearance endpoint was over 500 microns. So then the question is, why is it that even just 2 months after, we start to see this significant improvement in the ocular surface, and 2 years out, this is a pristine looking cornea with regression of neo, regression of haze, and regression of lipid keratopathy, despite this clearances, right? So is it the fact that clearance is not the main factor leading to good physiological endpoints? Could it be the way we fitted these lenses to try to make sure that these lenses are not tight? Could that be what's driving this? Could it be that we're allowing tear exchange under these lens fits? Could it be that there's no suction? You know, there's a lot of things that could very well come into play here. And these are the questions that we need answers to, right? So the next case that I'm going to share with you is that of a 23-year-old woman who had neurotropic keratopathy. And she came to her clinic mainly with the goal of healing persistent epithelial defects that were recalcitrant to other therapies. She had failed lateral torsorrhaphies and other soft lenses and other modalities, including serum tears, and those defects had not healed. So fortunately, with the use of our devices, we proceeded to fit this patient. This was back in 2006. Again, back in 2006, even less. There was no notion of potential impact with clearance, right? But we always had this philosophy, this style in the fitting approach. So that has stayed the same throughout. So much so that in the medical record, the way we would qualify the clearance, it was either generous, adequate, or shallow. We would not even put a number to it. This is back in 2006. And so believe me that when we label these faults as generous, we're talking way beyond 500 microns, right? And so fortunately, we were able to resolve these epithelial defects in 12 days. But as you can imagine, we had significant sequela of opacification from this defect and neovascularization. These are her eyes. And so you can see the dense opacity in both eyes. But you can see, and then you can see some feeder vessels where the PEDs used to be. But again, the left eye is way more compromised. You can see that there's much more extent of the feeder vessels, but you cannot see any pupil structure behind. So we fitted this patient. The goal was to heal the defects, and then the patient was going to continue to wear these lenses to support the ocular surface and hopefully prevent further epithelial breakdown. The patient was from out of state. This is not something new to us. We handle a lot of patients from out of state, and so we co-manage with the referring doctor. So we sent a letter to the doctor, and the instructions were that, the patient was to follow with the corneal specialist and return to our clinic in 6 months. Well, as it may happen to a lot of you, this patient actually, unfortunately, did not return to clinic. And so what we tried to do was to reach out to the corneal specialist over time just to see how the patient was doing. And we were just obtaining medical records until we were able to see the patient. So in 2007, we obtained the medical records. The report is that the patient was doing well. There was no more PEDs, which is great, stable ocular surface. But the corneal specialist relates to us that there is still dense opacification. The vision was at 2400 in both eyes. In 2008, the patient doesn't return again. But now we start to see a little bit of change because now we have a report that this ocular surface is stable, but the vision is actually improving, especially in the left eye. Well, both, but the left eye a little bit more, from 2400 to 2100, 2080. So that was encouraging to us, even though we were not seeing what was happening. But the report was that there was still some opacification. Finally, I'm not going to belabor the point, that the pattern continued and we continued to stay in touch with the corneal specialist. The patient doesn't return to our clinic until 2012, fast forward time, mainly because she was having problems with the fit, comfort in the right eye. So it seemed when we evaluated that lens over time became a little tight. It was a little suction. When we tried to remove the lens, it was hard to remove. And you can see that from the hyperemia in this region after we removed the lens. 2100 in the right eye, but by then the left eye that was well fitted and had no complications, the patient was super comfortable, the vision was already at 20/50, and look at the presentation in that cornea already. And this is again with generous vaults, clearances of over 500 microns and beyond. There's already significant clearance without any complications of edema, potentially from this hypoxia. And so why is it that we hypothesize that the reason we saw this significant clearance in the left eye and not so much in the right eye, it was perhaps because of the way the endpoint of fitting in this eye, it was looser, and we think there was less suction over time. Perhaps there was more tear exchange and oxygenated tears could flow underneath. In comparison to this eye that over time got tighter, this is the reason the patient eventually returned, and this eye didn't benefit from the benefit that the left eye had. So the patient, in conjunction with a corneal specialist, decided that they wanted to have a corneal transplant, which they did. And so back in 2015, and I should say that on this occasion, because the patient was doing so well, we didn't change the fit in 2012. All we did was order a replacement device, just a replica, just so that the patient could have a new backup because this lens was particularly old. So fast forward time, 3 more years, the patient returns so that we could refit the eye that had been transplanted. We kept the same fit in the left eye and see, it still had generous vaults, but look at the progression in that left eye. From 2006, how we started, to see significant clearing in 2012, 6 years, and a total of 9 years with the same lens, same type of fit, but just distributing the weight, no tightness, etc. Even with this generous vaults, look at the significant clearing, right? So what gives, right? There's got to be something more. And that's what we would hopefully learn from today, is that we need to look at the whole system in order to hopefully obtain this good physiological endpoints and not over-focus on just the one parameter. Just the last case in this series is this patient of mine that we published this case report in Optometry Vision Science and OVS just recently in December of 2020. But this is a patient of mine that has been with me for many years. She suffered an accident, a car accident that led to have this traumatic lid ptosis in the left eye. The right eye has a tarsorrhaphy, a lot of complications with a rupture. So that eye is really non-functional. So in essence, this patient is monocular. The reason they refer this patient to us, and I started to see her, she's from Honduras. I was able to help her. unfortunately, Spanish is my first language, so I was able to help her, is that the surgeons did not want to do more surgery to try to lift that ptosis because it carried even more risk. So they approached us to see if we could use a scleral lens and use it as a lid crutch. And at the time, what we decided to do, or we thought that we could do, was actually, instead of fitting the patient with your typical clearance, perhaps, just go even more, right? If you increase the clearance significantly, this is the patient without the lens, and she has to look, tilt her head in order to see through, right? This is a compensation. And this is her with the scleral lens. You can see now she has a more normal posture, and then the lid is lifted. And so she could be the girl that she was, a 9-year-old girl, and be able to go to school and so forth, right? But then the question is, what would happen over time with the physiological endpoint in this patient? This is a pediatric patient, monocular patient. So it was a lot of responsibility. And, obviously we had to monitor very closely this patient. Fast forward over time, 9-8 years. Now she's much older. And what I did was to continuously increase the diameter of that device, because I figured that I wanted to distribute. It was such a tall lens. I always was concerned that the higher the lens, it would lead to settling over time and to compression over time. And then I potentially have issues with suction. So I progressively continue to increase the diameter of that lens. At this point, she has a 19 millimeter diameter. This is the clearance as measured by OCT is at 1,100 microns. So it's a significant amount of clearance in order to obtain this result with the lid. But you can see that we're distributing that weight over a broad area. You can see here with the OCT. And you would argue, what happened to that cornea? Did we compromise this or fragile cornea over the years because we chose to do this lid crutch approach? Well, this is how the cornea came, presented to us, with a lot of synechia and a lot of haze in the surface. And you can see, this is the reason why it was published, because we wanted to share that not only did it not get worse over time, over the course of 8-9 years, but it actually looks better. You can see progressively how the cornea is actually clearing. And a lot of that haze that is in the periphery and the cornea, especially around here, is actually clearing, despite the fact that we have 1,000 microns. So again, what gives, right? There's got to be something more to this. So this is what I would love for all of us to take from here, that maybe is the whole fitting approach that is leading to these great endpoints. So now moving forward, and similar to topic, but what happens when we have patients with old grafts or compromised grafts? Do we need a specific number of endothelial cells in order to achieve good endpoints? Is it that with really old grafts, scleral lenses, especially because we're concerned about hypoxia, we're going to compromise the results for these patients, or maybe pose more risk to them? Well, let's see these two cases. This is a 60-year-old woman, a patient of mine, who comes with original grafts. She has not been regrafted. These are 40-plus-year-old grafts, okay? She has been wearing our devices for 13 years. These were pretty ectatic grafts. And because, again, the corneas to begin with are pretty protruded, I dispersed the weight again over a broader surface area and chose to fit her in 19.5 and 20 millimeter lenses. At the time, whenever we have grafts, we always try to maximize the DK over T, the permeability. So at the time, the highest material I had available was Boston XO2. Today we have Optom Infinite, and soon, hopefully, Acuity polymers, which the DK are 180 and 200. But at the time I had Boston XO2, 140, and the thickness was 260 microns. So this is a good TK over T to maximize permeability over these lenses. So this is how these lenses look. These are examples, pictures of these graphs. And back then, originally, the thickness of these corneas when I started fitting them were around 550 and 687 microns. 13 years after, we keep measuring the corneal thickness. You can see that the thickness 13 years after are pretty much the same within the standard deviation of the error of the measurement. And this woman has 20/20 in both eyes 13 years after with original grafts, 40 plus years old, without any complications of edema or neovascularization or rejection or transplant failure, even though the vault in one of these lenses was 600 microns. So it was a pretty large clearance. The other eye was more like closer to 250 or so. That's more acceptable to us these days. But this patient, again, was fitted years ago, and she has great outcomes even with a larger vault. We share this case in Contact Lens Spectrum in an article we wrote for them. So again, you know, what gives, right? Let's see this other case. This is another case of a 40-plus-year-old graft. Is a gentleman who had grafts in the right eye from 1978 original and the left eye from 1980. He has been wearing our lenses for 19 years, so almost 20 years of lens wear. This is why these cases, in my mind, are so relevant, because these are true patients, right, with real disease. We have provided successful visual outcomes for this patient 2020 since then, but the approach that we took starting in 2005 was to start fenestrating these lenses. When you fenestrate scleral lenses in the optic zone, what you're aiming to do is really minimize the suction so that these lenses go in and out very easily and you're not compromising the graft. Again, we fitted him in 19.5, try to optimize the DK over T. That's key. You should always do that in general, but especially with all your grafted patients. Make sure that you don't have a thick lens and you try to go with the most permeable material that you have available. This is an example of this fit, long-standing since 2005 with 20/20 vision. But the patient comes to me complaining that the bubble, right, you're going to have an air bubble as a result if you put a fenestration in the optic portion. From time to time, it would encroach into the visual axis, and he was starting to have complications from the bubble. Especially at night, he would notice some glare. And so he thought it was time for me to reevaluate and reassess what could we do. So at this point for this gentleman, I kept him in the same device. The goal, again, no marks left behind, that you make sure that it's not tight. We're not compromising the limbal zone, right? So what I decided to do is that we proceeded with a proprietary design where we do a circumferential channel around the lens, and then we add the fenestrations around the channel. With this, you can see then the bubbles are constrained just to that area of the channel. So you're still minimizing suction, but that way the bubble doesn't encroach into the visual axis. I can share a video with you just so that you can see a little bit better the dynamics of the fit. I'm going to advance it here to about 12 seconds here. You can see the fenestration there, and you can see the bubble, and you can see how it nicely stays within that channel. And when we lift the eyelid, you can see, I'll show you, there you go. I'm going to show you now. You can see very nicely where those bubbles are limited to that endpoint, to that channel. And now the patient is comfortable, is happy, 20/20. Clearances in this case, we did reduce the clearance because we kept it there, but we kept it in the channel. We have to decrease the clearance, otherwise the bubble will encroach the visual axis. But the key is that these two cases, you have successful endpoints, 13 years, almost 20 years out, no complications of hypoxia. You can have good endpoints with older grafts. If you need to fenestrate, then fenestrations would be the way to go. But in some cases, even with a large vault, you can still be successful. So there's something else that probably we need to take into consideration. And as I said, it's probably looking at that whole, the whole system in the fit. And so the last topic we're going to be talking about today, and then wrap up for questions, is the effect of scleral lenses on intraocular pressure. This is another topic where we're learning more about, which is good. And there's been some concerns that have been raised by some studies that perhaps scleral lenses affect the IOP and can lead to a rise in IOP. Some of these studies, again, smaller studies, so we have to, again, take those and take that reality into consideration, right? And there's a little bit of discrepancy with the different modalities of IOP measurements, where there's not necessarily consistencies in the findings, but I'm hopeful and optimistic that a lot of more attention is driven into this, and then we're going to be learning more. But let's just take these two cases just for us to question, right? And see what we can learn from these. This is a case of a 63-year-old woman that needed to be fit with scleral lenses because she had significant keratopathy secondary to chronic exposure. That was the main indication for fitting. But she had concomitant glaucoma at the time. And so we had fitted her back in 2016. And after we had fitted her, she actually required tube shunts in order to manage the glaucoma. This is an example of the tubes. You can see how they come through the angle, and you can see that in both eyes. And what we tend to do, so this is a little tip for you all, if you have patients like this, and you can work with your manufacturers to help you with this. You can draw with a Sharpie on eye, you can do an extend. It would be great for you to create a channel of sorts, or a tunnel, or a vault over that haptic, so that you're minimizing even further any pressure over the area where the tube shunt is. The goal here is twofold. You don't want to put added pressure over the drainage system. That's number one, obviously. But number two, you don't want to rub the conjunctiva too harshly, because if the conjunctiva becomes eroded over time from pressure from the haptic, you could potentially have complications from endophthalmitis. And that's something that we really don't want in cases like this. So my advice to you from a fitting tip is work with your manufacturer, see if they can create a channel, like a tunnel of sorts, especially where that tube shunt is. This is what we did for this patient. And the goal, as I mentioned, is so that when you remove these lenses, this should be your final, the last thing that you always do with your scleral lens fits is evaluate after removal and after staining. And the goal is that you in general, you see no marks left behind. You see that there's no imprint of the edges, so that lens is not tight. But also, you don't want to see any staining over the area where the tube shunt is. And with this approach, this has been our goal. And you can see when we remove the lenses, there's no hyperemia as well. That tells you that that lens is coming out nicely and no suction. You can see the tubes there again. And so when we've taken this approach, you can see the outcomes over a 3-year period. So the pressure before surgery, before the tube shunts, were in the 20s, which is why the glaucoma specialist decided for this particular patient that they wanted to proceed with the tube shunts. After surgery, the pressures were 9 and 15. The pressures throughout the adaptation were pretty much within the margin of error, the same, 11 and 16. And 3 years after we fitted this patient, the pressures pretty much again stayed the same immediately after surgery, again within the error of the measurement, pretty much the same. So there's no real change in IOP over a 3-year period. The last case I'll share with you is a 73-year-old man who had keratoconus and dry eye, and that was the reason why he needed to be fit with our lenses. But he also had a history of glaucoma. This is very common, right? We typically, when we're dealing with complex corneal diseases, it's not just one thing. There's potentially other concomitant diseases that we have to be managing as well. And so he has a history of glaucoma and a history of tube shunts in both eyes already. In order to manage further his glaucoma, he was already an ASOP, twice a day OU in both eyes, but he had hypersensitivity to these other glaucoma drops. So he was someone who was monitored very closely because his glaucoma was a little bit aggressive at the time. We decided to fit him in a 23 millimeter lens, not because of the glaucoma. This is back in 2008, but mainly because the cornea was so protuberant. As I said earlier, our fitting philosophy is to always try to distribute the weight of the lens as much as we can to avoid issues of compression and avoid issues of suction over time. We do believe that this is an important thing that we should all be paying attention to. So back in the day, we decided to go for a 23 millimeter lens, 20/30 endpoint, without knowing the year after we fitted this patient. This was 2008. It's a patient out of state. Without us knowing, in 2009, the patient had underwent a combined cataract surgery removal, and with an addition of a filtering bleb. And the patient, he didn't come back. He actually continued to wear our device, our original device, without us knowing that he had a filtering bleb afterwards. When the patient comes back to see us, this is in 2013, and we learned that this is all went through, we were concerned because we were concerned that what happened to the filtering bleb? Did we, by you wearing the lens, could you have compromised your glaucoma, your pressures, etc., because we didn't take the time to add the channels or vaulting over it. It just so happened by virtue of going with a 23 millimeter lens and by virtue of not fitting tight. And that's one important thing I would like to stress and highlight, is to always strive to avoid tight fitting endpoints. Those are going to probably lead you to more complications than the latter, than the endpoint of, ending on the little bit, not loose, but, aligned to a little bit loose. The lens vaulted over the bleb. And so we obtained records from the glaucoma specialist just for us to know what has been going on throughout this years. And we saw that IOP was stable over a course of 5 years, and visual fields, no changes in visual fields over 5 years, despite the fact that the patient continued to wear the same lens. So these cases of, a little bit longer duration is showing us that perhaps not always are we affecting the IOP, or not always are we affecting the visual field. So I think this is another area that we have so much more to learn. And I think that the future is bright in this topic. So it's, for us to stay tuned. It's to be determined, if distributing the weight has something to do with these good outcomes, is if trying to minimize suction again has something to do. We don't know. So these are the things that we need answers to. So in conclusion, what I hope I communicate and I'm able to relay today is that it is important for us to not over-focus in just the one parameter when we are aiming to achieve good physiological endpoints. It's not just about the clearance. It's not just about the limbal vault. We should have the whole system. We have to make sure that we have good distribution. We have to make sure that we are clearing the limbus, that we're not having tight lenses, that when we remove the lenses, we don't have any marks left behind, etc. So look at the whole system and try to achieve all of these. And hopefully that is what's going to lead all of you to have good physiological endpoints like I've shown today. Not all the fits are the same. Not because you're putting a scleral lens, a piece of plastic in the eye, you're going to get the same endpoints. We have to make sure that we, again, as I said, take all of these fitting parameters into consideration and obtain good fitting endpoints. Does suction have a role? Is that important? We don't know. And that is something that we're hoping, at Boston site, hoping to shed some light on, hopefully in the near future with all of you. We're actually started a study around this because I think it's important to learn more about this as well, because it's something that is not spoken too much about. And so to conclude, we definitely need longer term studies. These small studies are important, but they're not the end be all. And I think we need longer studies and larger sampling samples of, larger ends in order for us to have more reliable endpoints and derive more reliable conclusions. So with that, I hope you enjoy, and I really thank you for joining, and thank you for your attention.
Okay, so I think thank you very much, Doc, for that wonderful sharing of cases. I think the whole idea was to look at those long-term cases. I think your follow-ups were more than 6 to 8 years, and you had that follow-ups, and very important to see the good progression and the patients getting benefited with that. Thank you so much for sharing that with us.
My pleasure.
I just wanted to ask, what about the filling solution for these? Because the volt in one of your cases was more than 1000 microns. So any special filling solutions are used, or the normal Nutrifill or saline are good enough?
So back in the day, we didn't have solutions like Nutrifill that have these electrolytes, right? Back in the day, we used a saline solution called Unisol, made by Alcon. That solution is no longer used, but in essence, what it was a buffered, sterile, preservative-free saline solution. And I think that the key is obviously that we are dealing with non-preserved saline solutions. I think that is the key. We in general recommend like the buffered solutions, because we have seen cases of some hypersensitivity in some of our patients when they use the inhalation saline to fill these lenses, which have proven to be a good alternative for a lot of our patients. But for some, perhaps with ocular surface disease or more compromised surfaces, the swing in the pH, sometimes with more acidic pH, can irritate the cornea. And this is at times when we remove the lenses, in theory, we should not see SBK in the cornea if you're wearing a scleral lens that is bathing the cornea throughout the day. But yet, sometimes we have seen that it's like a medicamentosa type of presentation in the cornea. And when we go and check, these are not buffered saline solutions. So on these occasions, we actually switch patients to buffered saline solutions, and we see that this improves. Now, with the advent of different saline solutions, especially with this added electrolytes, I think we have seen some good endpoints in some of our patients. Admittedly, I will say that I have not tested in large ends, but I think I will have a better idea soon, because we're testing it more and more and more with more patients. So I think it's encouraging that more attention is paid into this, and then we're having more options for our patients. Absolutely.
That's right. Okay. And in your cases, it's just, I think, a common question, I guess. How often were the scleral lenses replaced, or do you have a fixed replacement schedule which you would advise your patients? Does it depend on the lens design? Does it depend on the condition? Any tips on that?
That's a very good question. In theory, scleral lenses could be indicated for waking hours. As long as you're awake, in theory, you should be able to wear your scleral lenses. But no doubt that we certainly have modified the wearing schedule for our patients depending on the condition. If the cornea is pretty fragile, the ocular surface is pretty fragile, and the patient is also predisposed to develop edema, cystic epithelial edema, we have recommended at times to take breaks. Maybe you wear the lens for 4 or 5 hours at a time, remove it, take a break of 2 hours or so, and then you can reapply. I will say that is not most of our patients. Most of our patients are able to wear the lenses every waking hour, but undoubtedly, we do have patients that we have to modify the scleral lens wear, period. And the reason I like and appreciate the question is because this highlights yet another important factor, is that not every patient is the same. Just like not every fit is the same, not every patient is the same. So we cannot assume that all of our patients are going to behave or have the same outcome. We have to tailor the wearing schedule, the way we fit. Either we go smaller for some patients, we go larger for others. It's a personalized approach for the patient depending on the condition. So absolutely, you can vary the wearing schedule as to meet the patient's needs.
Okay. And anything on the replacement schedule? So would you want them to replace lenses every year or 2 years, or any such rules of this thing?
Yeah, so we don't have a set rule, to be honest with you. For us, if the fitting endpoints are proving to be physiologically compatible, and again, we just mentioned what that means, especially, no touching the limbal zone. When we remove the lenses, that's key, that we don't see rebound hyperemia. That's a sign of compression, that we don't have tight fitting lenses. And the patient is comfortable and the vision is good. We have let the patient, to be honest with you, go with the same lens for sometimes 2, sometimes 3 years. We do want to see the patient sometimes every 6 months, sometimes every year. I will admit that for grafts, we don't do yearly follow-ups. We do 6 months follow-up for our grafted patients. Some of our ocular surface disease, we also monitor every 6 months, because we don't want to be playing catch up with these eyes. We want to be on the offense, right? We want to be proactive and monitoring closely. And so, yeah, no set rule around the replacements. It's only as needed.
Okay. And we did talk about the glaucoma shunt patient, and just asking what modifications were made on the scleral lenses. So you did mention you take a Sharpie and you mark the area of the shunt, but was the edge lifted, or was there anything specific which you would want to let us know?
Yeah, so I think this is something that thankfully most manufacturers, scleral lens manufacturers, have access to, and certainly Boston site is one. We have the ability of carving underneath the haptic surface a channel. You can think of it as a little tunnel, if you will. That's why the Sharpie outline was pretty wide, because we don't want to make it a very narrow, tall channel, because then again, the edges, it's going to rest very sharply on the conjunctiva and cause some compression issues. So we want to make it a wider channel so that when it lands, it doesn't land exactly where the tube is, but lands a little bit, progressively on the sides. And that is something that Boston site lenses can do, the design, but this is something that you can have access with other lenses as well. You just have to work with your manufacturer and ask them to create this bolting underneath the haptic for you.
Okay, great. And how would you select the base curve and diameter in case of post-keratoplastic patient? Is there any specific criteria? Is it different from fitting a non-graft patient, or anything which you would like to discuss?
Not necessarily. So again, you're going to have different designs. There are some designs that are base curve dependent, that the base curve dictates the clearance, going up or down. There's some other designs where this base curve is independent of the sag, where you can control the sag up and down in microns, and the base curve only controls the peripheral clearance part. That is certainly the way our lenses work. But the approach, the philosophy is really no different if we think about it from a keratoconus patient, from a regular cornea patient. What is going to change for you is ultimately the net clearance or the total sag that you're going to need in order to clear over the cornea. Obviously, that will change. The way we teach our fellows and our students these days is that it's good to aim around a net clearance of about 250, 300 microns. You know, if you can aim for 250 clearance, I think it's good. You prevent issues with settling and then touching. You don't have an excessive clearance either. But in order to have a net 250, the total sag height might change. It might vary depending on how protruded the cornea is. The key is that when you clear the center of the cornea, that you don't forget the periphery. You know, let's not over-focus on the center. When we go out into the periphery of the cornea, we want to make sure that the limbal zones 360 degrees is not compromised, and we're not suffocating the limbus, that we are clearing it, and that we want to distribute the weight over a larger surface area. So our approach is that if we are dealing with an ectatic graft or an ectatic cornea in general, we go with a little bit more plastic on the conch so that that weight is more evenly distributed. But the fitting approach is pretty much the same.
Okay, great. And this is again related to scleral lenses and IOP. What probably would be the reasons of what you think, because of the confusions or because of the various results which we did talk about scleral lenses and IOP? Is it anything which you would like to say?
Yeah, so I think that a lot of the studies that have come out that perhaps raise concerns and issues, some of these instruments are not really validated for IOP. A lot of these are through the lid, one of them at least. And so I think that because we have the studies that were coming out have measurements from different techniques and some of them not being validated, I think that's why the results are a little bit all over the place. I trust that because there's more attention to this, that more studies will come, or perhaps there's more like a standardization. Hopefully there's validation that has been now happening for a lot of these measurements, instruments, I should say, and that we learn really more, especially long term. I take it a little bit with a grain of salt, some of the results that are coming out there, just because of some of the outcomes we have seen in the clinic. But at the same time, it's important to note that there's a lot to be learned. And if we learn that, in fact, some aspects of scleral lens fitting can compromise IOP in some ways, it is certainly something that we need to know, because we need to be able to care for our patients adequately. My opinion is just that it's too preliminary. And I think that the studies that are out there are starting to shed some light, but I don't think there's any conclusive data yet for us to make any definitive conclusions one way or the other. I think we just have to be very mindful. If we have a glaucoma patient, perhaps think about that patient as your graft patient. Monitor them more closely. Don't let them go a year out. Try to just do close monitoring. Just hopefully, if there's a complication, you can catch it up in due time.
Yeah, that's right. And then again, it reinitiates your first point that every patient is different. So if you have patients who is probably a glaucoma patient, or his initial IOPs were high, monitor them more closely, and probably you can get your answer on follow-ups, right?
Absolutely.
And a couple of more questions. Does reducing or increasing the volt significantly affect the haptics fitting, or does it compromise for that?
That's a good question. Not always. Not always. It could though. Meaning, what do I mean by that? If you have a very tall lens, right? Let me qualify the answer a little bit better. It has been studied. There are studies out there that have shown that smaller diameter lenses settle more over time than larger diameter lenses. There was a good paper by Kaufman, Bennett, et al. Around this topic, where they studied the amount of settling over time, and it was shown that when you have you're sitting in the area of the conch closer to the limbus, perhaps the conch is thicker, and we know that the conjunctiva is a mushy tissue, so the lens has more give, so it continues to go down. Not so much the case when you're dealing with lenses that are landing farther out from the limbus. And so the reason I say it might is because if you have a very tall lens and you're fitting in a smaller diameter, the weight of that lens, because it's so tall, in a lens size that will by itself continue to settle, it could lead to compression over time, and where you might have a good fitting endpoint at the beginning, immediately after fitting, you see that the haptics are kind of aligned, and then you see the patient maybe 6 months or a year out, and all of a sudden you see the haptics that are a little tight, and you might wonder, how come this is happening? And it could be that the lens has settled over time, especially if you have a high clearance, which is why we have always thought that if we're going to have the total sag height of a lens, if we're going to have a tall lens, if you will, that we actually add a little bit more real estate or plastic to the side, and we go a little bit larger, so that we have less of these effects over time, less compression over time.
Okay, great. And would there be any change in fitting philosophy if you have patients who you are treating them for ocular surface disorders compared to compromised corneas or keratoconus for that matter?
So that is for ocular surface disease. Our approach is for fitting is the same, but one thing I will say that is a little different, something that we do consider for OSD that not necessarily we consider for irregular cornea patients, is that we always stain the cornea at baseline, right? We stain the ocular surface, right? We use sort of fluorescein, we can use lissamine green. And it's important when you're dealing with severe dry eye or Stevens-Johnson's, graft versus host disease, compromised surface exposure keratopathy, etc., that you look at the staining pattern of the ocular surface, not just the cornea, because many times you're going to see that the conjunctiva lights up probably as much as the cornea, sometimes even more. And when we choose the diameter to fit this patient, we at times focus only on the cornea. Oh, it's a regular cornea. It's not an irregular cornea, so I don't need to have it's not going to, the total sag height, it's not going to be enough. So maybe I'm going to fit this patient in a 16 or 16.5 or 17 millimeter lens. And while that is good for most of your patients, it might be, again, not all patients are the same, that if you're dealing with a patient that has significant dryness beyond the cornea into the conch, if we go larger, we protect more of the ocular surface from desiccation and from the environment, of external environment. These patients do better. We have many cases where we started with a smaller diameter, and the cornea is fine, but there's a lot of hyperemia on the conjunctiva, and where the patient says, I do better, doctor, but I'm still uncomfortable. There's a sense of discomfort. And then we just go a little bit larger to protect more of the entire ocular surface, and then the eye quiets down. So take that into consideration and always look at that ocular surface baseline. And that will dictate if you need to go a little bit larger or if you can stay with your smaller diameter lenses.
Okay, great. That's very useful. And one last question before we wind up for today. Any precautionary measures in terms of patients who require anti-glaucoma medications while wearing the scleral lenses? So any tips or any things which you do differently for that?
Can you repeat the question, please?
Yeah. So any tips on patients who are using anti-glaucoma medications with scleral lenses?
Yes, a very good question. So one thing that we have learned by co-managing these patients with corneal specialists in the clinic and co-managing with glaucoma specialists is that lowering pressure medications or glaucoma medications a lot of the times are preserved, right? Most of them are preserved. And the preservative in these medications most of the time is BAK, benzalkonium chloride. And this preservative has been shown to be toxic, if you will, to the ocular surface. So you are using the glaucoma meds to lower the pressure. But if on top of that, you have a patient that has ocular surface disease, right? And it's not just the glaucoma and the optic nerve, etc., but now you have issues at the ocular surface. These two will not necessarily go well together. The use of these preservatives can impair or can make the outcomes at the ocular surface even worse. And we have seen cases like that. So it's important that you co-manage well with your glaucoma specialist and then be proactive if they need a scleral lens, because thankfully today we have access to non-preserved glaucoma medications. I don't know about the access globally, but I know that there are various medications, at least that we have access to, that are non-preserved. And so you can get the IOP target that you want, but you are more friendly to the ocular surface and you can obtain better endpoints for your scleral lens patient. And the last thing that I will say is that thankfully, most of these agents are used in a BID fashion, so twice a day or at night. So the good thing is that it really doesn't interfere with the scleral lens wear, because the patients will put the drops either before they put their scleral lens or at night when they remove the scleral lens.
That's right. That's right. Yeah. And I think most of the pharmaceuticals are now coming up, as you said, with preservative-free drops. And I think that would be much more easier for the ocular surface. I mean, whether you are wearing a scleral lens or not wearing a scleral lens, it's good for the ocular.
Absolutely. Yeah. So that would be my recommendation, to keep that in mind.
Okay, great. So thank you very much, Dr. Karen, for that wonderful sharing and, taking us to the cases and answering the question. Thank you very much.
My pleasure. My pleasure. Thank you for having me.
Yeah, most welcome. And I see the chat is getting filled up with the thank you messages for you as well. So yeah.
Thank you to all who attended. It was really a pleasure. So thank you for taking the time and joining us today. I hope you have a wonderful day.
You too. So
take care.
Take care. Take care. Bye-bye.
Okay. Bye-bye.
And we do have sessions planned next weekend. Until then, take care, be safe, and I hope to see you all again next week. Bye-bye.